Good afternoon, everyone, and thank you for the opportunity to present today at this continuing professional development event for the Australasian College of Paramedicine. In today's presentation, I will propose how paramedics might modify their out-of-hospital practice to better engage with Australia's First Nations peoples, our Aboriginal and Torres Strait Islander communities, with the aim of improving communication, trust, and health outcomes. In this talk, I will start by introducing the population group and argue why improved engagement is needed, then going on to describe how past community engagement initiatives have reshaped paramedicine and out-of-hospital practice, before presenting my proposed resources and strategies to engage with the First Nations communities, followed by how these changes could be implemented, and finally how the suggestions support organisational effectiveness and benefit the wider community. The population in discussion today are First Nations peoples in Australia, Aboriginal and Torres Strait Islander individuals and communities who continue to face health inequities marked by higher rates of preventable illnesses, lower life expectancy, and poorer access to culturally safe health services. Research indicates that culturally unsafe care, communication breakdowns, and mistrust of health services contribute significantly to these inequities. In the out-of-hospital context, paramedics represent a first contact point for acute presentations in these communities. Yet studies show that paramedicine practice has not yet been aligned completely with culturally safe, community-led engagement. Given this gap, it is both ethically and morally imperative to improve how paramedics engage with First Nation communities to support equity in care and enhance service delivery. In exploring the current challenges to paramedicine practice in relation to First Nations engagement, it is key to delve into how community engagement has previously influenced out-of-hospital care. One key challenge is that traditional paramedic models are orientated towards emergency response and transport rather than community-centered and engaged care. Because of this system, it often fails to account for contextual, cultural, and social factors that influence health in First Nations communities. The concept of cultural safety, defined as delivering care in a way that is free from racism, power imbalance, and respect for cultural identity, has been widely discussed in health services. Yet, paramedicine literature indicates a gap in paramedics' understanding of this concept. For example, a study of Aboriginal and Torres Strait Islander patients found that feelings of cultural unsafe environments, poor communication, and distrust in the hospital context contributed to self-discharge and disengagement from care. In terms of paramedic practice change, there have been examples of extended or community paramedicine models in rural and remote Australia that engages communities beyond emergency response. One such model is a community paramedicine initiative in Wiluna, Western Australia, where the local Aboriginal medical service employed community paramedics who provided clinically based in-home and outreach care in collaboration with the community. This model improved rapport, reduced barriers, and built continuity of care. From these examples, we learned that meaningful engagement with communities, meaningful design service delivery, and shifting paramedicine practice beyond transport can reshape how out of the hospital care is delivered. My proposal that I will discuss today is to establish a culturally safe, community-led engagement model within paramedicine that shifts some aspects of practice from purely emergency response to proactive outreach with a focus on health education and partnerships with local Aboriginal community-controlled health organisations, also known as ACHOs, and local elders. The key resources and strategies would include firstly creating a First Nations community advisory group composed of elders, community health workers, and representatives from ACHOs and paramedic services. This advisory group would co-design the engagement model and guide all communication to ensure cultural relevance and appropriateness. Secondly, paramedic staff would receive training in cultural safety, communication strategies, and local cultural knowledge in the form of continuous professional development days like today. The literature emphasizes that working with Aboriginal health workers and community leaders is vital in building trust and ensuring respectful practice. Thirdly, I propose a community paramedic outreach role where paramedics partner up with ASHOs to visit communities, both in remote and metro, to deliver health education sessions, perform risk assessments, for example, wound care, infection, and chronic disease monitoring, and follow up on earlier contacts. An example from rural/remote Australia shows this model improved community integration and continuity of care. Communication resources such as culturally adapted brochures, video content, yarning circles, and local language options would be developed in partnership with community members to ensure health messages reach and resonate with First Nations peoples. The proposed modifications to paramedic service delivery are embedding cultural safety practices into every patient interaction with First Nations peoples, diversifying paramedic roles to include outreach and preventative functions, strengthening partnership with ACHOs, and introducing referral pathways instead of automatic transport to hospital where appropriate. Expected improvements include improved trust and communication between paramedic services and First Nations communities, reduction in avoidable ambulance transports and emergency department presentations, better health outcomes through earlier identification and community-based follow-up of acute and chronic problems, and also enhance cultural safety of care. So, implementation of this model could follow a rollout format. In the first phase, during months 0 to 3, the first task is to engage with the First Nations Community Advisory Group and conduct yarning sessions in various communities to understand and identify the needs of those communities, the barriers to engagement with paramedic services, their preferred modes of communication, and local cultural considerations. This will align with participatory research methods and ensures the service is genuinely co designed. In the following phase, months 3 to 9, the community paramedic outreach role will be implemented in the selected communities. Cultural safety training to be taught to paramedic staff, as well as to further develop communication resources in partnership with the community, and also to schedule regular outreach visits. The next phase, months 9 to 15, is where evaluation will occur, collecting data such as the number of calls, transports avoided, referrals made, as well as qualitative feedback via yarning sessions and community advisory input, all of which to aid in identifying barriers and enablers and refining the model accordingly. In the final phase, months 15 to 24, the model will be scaled across and completely implemented within all ambulance services in Australia. The community paramedic role embedded into CPD frameworks and ongoing community advisory oversight maintained. Within all ambulance services, change management strategies must include leadership endorsement, communication to all staff about the rationale and benefits of this new model, as well as workshops for teams, paramedics, community health, and ACHOs, recognition and reinforcements of cultural shift, for example, sharing success stories, CPD credits for cultural safety training, and also the establishment of continuous feedback so staff and community members can reflect, reinforce positive behaviors, and adjust practice accordingly. Organizational culture must shift to paramedics as partners in community health, especially for First Nations communities. This proposal supports organizational effectiveness of national ambulance services by promoting more efficient use of resources, strengthening workforce capability, and enhancing community trust. By enabling paramedics to undertake outreach, preventative, and referral roles, the service may reduce the number of non urgent transports and hospital admissions, thereby alleviating pressure on emergency departments and increasing service sustainability. For the wider community and stakeholders, the benefits include improved health outcomes for First Nations communities through identification of problems, cultural safe communication, and improved continuity of care. Furthermore, this contributes to reducing health inequities and aligns with national policy agendas around the health of Aboriginal and Torres Strait Islander peoples. For ACHOs and primary health services, the improved coordination with paramedic services strengthens system integration and reduces fragmentation and enhanced care pathways. Ultimately, a service model designed with and for First Nations people will help create more resilient communities, greater self determination in health engagement, and more appropriate and accessible care. In summary, Australia's First Nations people continue to face significant health inequities and barriers to culturally safe care, including in the out of hospital setting where they may engage with paramedic services. By co designing an engagement model that embeds cultural safety, outreach, referral, and partnerships with community led organizations, paramedic services can shift from reactive treatment to proactive and culturally safe community engagement. Implementation through co design, training, piloting, and evaluation with organizational change management and feedback mechanisms will support sustainable change. The benefits for the ambulance service, for First Nations communities, and for the wider health system are significant. Thank you for listening.